Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hi, Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in healthcare. Past guests include Dr. Beck, who's on again. He's a repeat person. He has a great prior episode. Why don't you go look at that? But we're excited to talk about some new topics. This episode is brought to you by Listen Up Hearing Centers. At Listen Up Hearing Centers, I help patients to effectively treat their hearing loss so they can remain more socially connected with their friends and family and remain independent. The reason I'm so passionate about hearing loss is because I lost my brother Robbie twice. Unfortunately, first to his hearing loss from radiation to his brain tumor, and then later from complications. I am the E of ENT. I only treat ear problems. I've done over 10,000 ear surgeries, and I've taken care of many more with nerve hearing loss and helped them to rehabilitate their hearing loss. I'm the founder of Listen Up Hearing Center, and I've written a book of the same name, Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more about that, go to www.listenuphearing.com. That's www.listenuphearing.com. We have a return guest. It's Dr. Douglas Beck. He's been on before. He has a BA in Communication Disorders and Sciences and a master's degree in audiology and a doctorate as well. His doctorate's from University of Florida at Gainesville. He has had an extensive and wonderful professional career. He started out at LA at the House Ear Institute, where I did my fellowship as well in cochlear implant research and intraoperative monitoring. He became the director of audiology at St. Louis University, the Department of Otolaryngology. He co-founded an audiology private practice there. He became the president and editor-in-chief of Audiology Online, speechpathology.com, and healthyhearing.com. And those are some of them are vibrant websites that keep on going. Recently, he was the vice president of academic science at Oticon. He retired, and now he's come back out of retirement to become the vice president of clinical sciences at Cognivue. And today we're going to talk about that topic. I'm excited to have you back. Always a pleasure to talk to you, Doug. It's pretty amazing. And so one of the things we were talking about in the warm-up was, what brought you out of retirement, right? And I said to you, I didn't think it would be something not compelling. So tell me your story about coming out and what drew you out.
Okay. Well, thank you for having me, Mark. It's a joy to work with you again. After 38 years in audiology and hearing sciences and hearing aids and cochlear implants and all that stuff that audiologists do every day, it occurred to me kind of about 2009, I started writing a lot about cognition and audition and how in 1949, there was a guy, Dr. Michael Bust, it's one word, M-Y-K-L-E-B-U-S-T, I think. Dr. Michael Bust wrote in the Journal of Speech Language Hearing Disorders that cognition and audition and emotion and language and psychology are all pretty much kind of the same thing. It's just a matter of what lens you're looking at it through. So in 2009, I started writing about this, about how important cognition is to listening. So Mark, you and I spoke last time about hearing versus listening. So for those who didn't see that episode, hearing is just perceiving sound or just detecting sound. That's the simple press the button when you hear a beep. That's a very small fraction of what audiologists do. Audiology is the entire peripheral auditory nervous system and the central auditory nervous system. And what happens is that as the sound gets deeper into your brain, into the superior temporal lobe, which is about here, right? As the sound gets there, other parts of the brain are involved. Right now, the people watching the show, their occipital lobe is involved. This where vision is processed. And if you have an emotional impact, if I say something particularly silly or stupid or smart, and somebody goes, "Oh my gosh, I never thought." Now it's emotional. So your frontal part of your brain is involved as well. I'm gesturing. So that is triggering mirror neurons in your brain that are sensory motor, so the whole brain is involved in listening. You could say that just the superior temporal lobe, which is also in medicine called Brodmann's area 41 or 42, also called Heschel's gyrus, that part of the brain is involved. Press the button when you hear the beep. But when you start to process and listen, when you assign meaning to sound, much bigger deal than press the button when you hear the beep. Press the button when you hear the beep is very, very important. It's the essence of our medical and audiologic diagnosis, because that tells us a lot. That's why we do that. That is what we refer to as the gold standard, right? Is the audiogram. That's just a small fraction. That's hearing. That's a small fraction of listening, which involves the entire brain decoding all of that neural information to make sense of it.
So I love your nuance with the terminology. And so listening is active. How about where would understanding or comprehension fit in terms of terminology in this circumstance?
Yes. So understanding, comprehension, listening, I those are more
Interchangeable.
synonymous. Yeah, yeah. And so this is a really important point now when you talk about coming out of retirement for Cognivue. Well, because they have really explored how to quickly screen for cognitive processes. You see, one of the things that you and I talked about last time as well is that often when somebody is aging, it's not just their ears that are aging, right? Their whole body is aging at the same time, and by the time they manifest auditory difficulties, the numbers are that about one third of all adults in the USA by age 65 have some sort of a hearing problem,
Right.
and it's two-thirds by age 75. Well, most of those you can see on an audiogram, but many you can't. There's 37 to 38 million people who will have hearing loss on an audiogram. But there's another 26 million. Now, this is the important part of today's discussion. There's another 26 million who have ADD, attention deficit disorder, attention deficit hyperactivity disorder, dyslexia, mild cognitive impairment, cochlear synaptopathy, hidden hearing loss, traumatic brain injury, neurocognitive disorders. They might have Meniere's disease. They might have dementia of one sort or another, and there's about a couple of hundred types of dementia. And so they don't necessarily have hearing loss, right? But they're manifesting that they're having hearing difficulty or difficulty understanding speech and noise. So it could be that it's entirely auditory, and it could be that there's other parts of their organizational or attentional or listening skills that are not working as well as they need to be. So it's important for us as hearing care professionals to look a little bit deeper beyond the audiogram and say, well, does this look like something that could be more of a communication, a supra, meaning above the threshold listening disorder, or is this just a pure audiologic event? So cognitive screenings allow us to rule out that there's something else going on that we need to deal with. So if I test a patient and I get mild to moderate sensory neural loss, which is very typical, you might find that in what we call presbycusis, which is age-related hearing loss. So you have that going on, and you have difficulty understanding speech noise. Could be that it's entirely auditory, absolutely, but that's not a silo. It could be there's something else that we're concerned about because maybe your executive function isn't as good as it should be. Maybe memory isn't up to speed. Maybe visuospatial issues, maybe tracking speed, maybe processing speed. So we want to look at these things because the goal is to help the patient. And audiologists don't even get involved in most of the rehab for any of those issues, right? It's just refer.
Right.
But the important thing is that these are not silos and they overlap. So somebody could have problems with their memory, problems with their visuospatial, problems with executive function. So they come in and they say to the audiologist or to the otolaryngologist, I have trouble understanding speech and noise. That might be the sign and symptom that triggers a cognitive screening, and it might trigger an audiogram.
Yeah, yeah. It's interesting as you're talking about that. Sometimes overdriving works too, right? In other words, I'm not trying to get too much into it, but if we amplify people a little super threshold or get them a little bit more, they seem to do better. I have a subpopulation of patients with normal audiograms who love their hearing aids, and they're at the lower part of normal, but they do love that rehabilitation. I think it's an overdrive phenomenon, maybe overcoming some of those other brain speed bumps, if that makes sense.
And there are quite a few papers in the literature now, Mark, that look at this. I've written two of them as team members with other folks, but then there's a bunch of them where we look at what happens if you just amplify the speech frequencies 3, 4, 5 decibels, and at the same time, you're reducing the steady state noise through a noise reduction program. And at the same time, you're improving the signal to noise ratio. And at the same time, and those are the patients that like it because it's a little boost in the signal without bringing up all the background. Right. And this is not new. 1989, Carissa Bennett published a paper in the American Academy of Otolaryngology Head and Neck Surgery, the flagship journal for the American Academy of Otolaryngology. She looked at about 100 patients, and all she did is give them a little bit of gain in the speech frequencies, and most of them hardly had any hearing aid, any hearing loss or no hearing loss. And 9 months later, 6 months later, she went back to those folks, and something like 91, 89, about 90% of them said, best investment I ever made my life so much easier.
Yeah, and it shows you that maybe that, again, if there is some sort of central or cognitive dysfunction, they obviously need to be evaluated, et cetera, et cetera. But it is kind of interesting that maybe boosting on the hearing side can overcome some of those other issues. And I think that's an evolving world of research to see what those people have and what you can and can't. I'm not trying to say hearing aids are the be all and end all.
Oh, no, not at all. Not at all. And, hearing aids are a great asset. And anybody who's thinking about it, virtually every state in the US kind of mandates you get a 30-day trial. So don't go out and buy anything, but try something. If you're having difficulty, first, see a hearing care professional, rule out that there's anything medical or anything dangerous going on. Second, see somebody who is a diagnostician who can actually do a speech and noise test, do a listening and communication assessment to really define where you're having trouble and what help you need. What are your goals? That's the whole essence of patient-centered care. A lot of folks who have no hearing loss whatsoever, but have hearing difficulty and have speech and noise disorders, that's 26 million Americans right there.
Yeah.
So for those 26 million, get a professional evaluation. Let's make sure everything is okay. And then, there's lots of solutions. Now, when you think about this, when you have children who are diagnosed with ADD and ADHD, when you have children with dyslexia, when you have children with auditory processing disorders, one of the single most common things we do as audiologists for those children is we give them an FM system, right, to use in the classroom. Now, think about this. 90% of those kids have no hearing loss whatsoever, but they're wearing FM systems. And the reason we do that is because their brains are plastic.
Better signals.
You're improving the signal to noise ratio. That's the entire issue. The teacher is speaking into a microphone, which now the child receiving it through the FM system has a much, much better signal to noise ratio, maybe 10, 15, maybe 20 dB better. And that's very, very substantial. So their brain pretty much learns what signal to pay attention to. And in many cases, 2 or 3 years later, kids don't need it anymore. They've learned their brain, because it is neuroplastic, their brain has learned what to pay attention to.
Yeah, and maybe giving them the ability to unburden of dealing with the signal to noise, right? In other words, the audiogram demonstrates normal threshold, but they still, because they're trying to process something else in the brain, you're easing that up for them to be able to do it. Like you're alleviating the difficulty of signal to noise in the classroom.
Right. And when you think about that now with older folks, like in my age group and beyond, signal to noise ratio is the main reason we fit hearing aids. When you think about most patients who wear hearing aids, they didn't come in and complain, I can't hear, or I have a mild to moderate sensory neural loss. They came in and they complained generally about one thing. The single most common thing they complain about is they can't understand speech and noise. And when you think about that, that's primarily a signal to noise ratio issue, because they can hear. What they can't do is understand. And now, so the first 75 years of audiology were about hearing. Right. Now the next 75, I think, are going to be about understanding, about comprehending, about listening. Because we've got hearing, we can make anybody hear. I can send you a patient who is functionally deaf, and you can do a cochlear implant, right? And even if they don't have an inner ear, now the FDA has approved, auditory brainstem implants. And these are not particularly new. You know very well. You were at House. Bill House did the first one in 1987. So it took all this time for it to get approved, about 33 years. That's not a surprise, because cochlear implants started in 1959. Bill House did 3 of them in LA in 1961. It wasn't approved by the FDA until 1986 for adults and then 1990 for kids. So these things take decades. They're not fast. But my point is, we have solutions for hearing that are very, very good. We have hearing aids. We have FM systems. We have
assisted listening devices.
Assistive listening, a whole array of them. I mean, there's hundreds of assistive.
You'd never name them. We'd be here for a couple hours.
T-coils. T-coils are go back to World War II, but they work great, and loop systems work fantastic. So we have a lot of solutions for hearing loss. That's I don't want to say solved. Science is never finished, but we know we can make people hear. What we can't do is make people listen, and that's the challenge for the next 75 years. And to me, that's based in improving the signal to noise ratio.
Yeah, I think you're spot on. I think it's going to be interesting because one of the reasons that it's a bigger challenge is because it's multifactorial, right? And
exactly.
So, like, even if you give them the best whatever, if they're in such an unfavorable listening environment, there's sometimes you can't overcome it no matter what, right? And I'm not saying that is or isn't the case, but even the educational side of people understanding that restaurants are difficult places to hear on purpose, right? And getting people to understand that. But yeah, it's going to be really interesting. So in terms of that, it sounds like to me, I mean, I don't know a lot about Cognivue. I mean, I have a rudimentary understanding. This is the beginning of getting the audiologist to be able to look at these other areas of listening. Is that correct?
Yeah. So,
or not to look at, to evaluate patients for possible problems, to refer them to other practitioners to get that part of the listening machine, if you will, tuned up.
Yeah, pretty much, because the audiologist is going to stay involved with hearing loss, cochlear implants, assistive listening devices, loop systems, things like that, the hearing end of it. But we have to recognize that hearing in and of itself is not enough. You have to be able to then interpret that sound and make sense of it, and that's listening. So it makes good sense to me that audiology and hearing care professionals in general would be very concerned about this, because this is the next step in the evolution of the science. We kind of understand hearing since von Beckeschi, and we understand traveling waves and cochleas and outer hair cells, inner hair cells, paralimb, envelope. We got that. We kind of know how that works. Not to say it won't evolve. 20 years from now, we're going to know a lot more about that. But listening in and of itself, this is a tremendous dilemma. Sometimes people have auditory processing disorders, which is a matter of what you do with what you hear, very similar to how we act cognitively and psychologically and emotionally to sound. We have auditory neuropathy spectrum disorder, which is reasonably common. One out of I would guess 1 out of 8, 1 out of 10 people, once they have a moderate hearing loss, could have auditory neuropathy spectrum disorder, and that's a matter of auditory dyssynchrony. So it's not how loud is it, but what can you do?
Arrival time of the information, right?
Yeah. So it's a very deep bucket, and we're just starting to scratch the surface. Again, a lot of us have been writing about it for the last 10 or 15, 20 years, but now we're starting to see screening tools come into the main auditorium, where more and more people are looking at them and saying, how would I fit this into my practice? What does this tell me? What does this not tell me? And when you get a positive result on a cognitive screening, that doesn't mean you have a cognitive disorder. That means you need a confirmatory test.
Means you have a positive screen.
Yeah, which is informative, and it tells you a lot, because but if it's negative, then you've ruled that out. So that's probably more germane, right? Is that we know that that's not something we need to consider. But it's the same with a hearing screening. If you get a positive result on a hearing screening, that does not mean you have hearing loss. It means you need a confirmatory diagnostic test. Same blood pressure test. You go to Walgreens, you slap on their thing, and the alarms go off and the clerks come running. Yeah, because you have 140 over 110 on their machine, but their machine may be out of calibration. Maybe you have 115 over 70. Who knows? And I don't mean to slam Walgreens. I'm sure that all of their machines are perfectly calibrated. But the
concept of a screen versus a actually comprehensive evaluation.
Absolutely, and this is the key, right? Is that so when audiologists are seeing patients now, if I see an airbone gap, if I see a conductive loss, an asymmetry, if I see a patient with unilateral hearing loss with tint, I'm going to refer to an otolaryngologist or back to their GP, depending on the situation, because I don't treat that. That's something that I have found that could be a problem. So we refer. That's a natural course of things. So the question is, are you looking at a broad enough scope to really do what's in the patient's best interest? And listening disorders, suprathreshold listening disorders, and attention to the signal that you're trying to pay attention to, and remembering it. These are all, as 1949, as Dr. Michael Bus said, they're all kind of interrelated. So we want to rule out if there's anything dangerous, and then we can move forward. But that's why you're seeing more and more audiologists get involved in screening, is to say, do I need to be concerned about anything else? And in particular, do I need to refer? Because if you get a positive screening, you should refer, or else what was the point of the screening?
So talking about from a patient point of view, okay, so if there was a concern, what would the screen look like? In other words, what's the experience of a patient undergoing a screen? In other words, what are the questions, or what is the task? What does that patient experience look like?
Right. Well, the most common screenings, out there are the MoCA, which is the Montreal Cognitive Assessment. And a lot of folks have seen that. You can simply Google it. You'll see a copy of the test. You have the mini mental state exam. You have the mini cog. You have the SLUMS, the St. Louis University scale. The Cognivue is different from all of those in that the patient runs it his or herself. Okay. So it's a digital test, and we try to get sensory isolation. So there's like a shading so that you're only seeing
Like a
the
hood.
screen. A hood, yeah. And then you have what's called the Cognivue, which is like a little joystick sort of a thing if you go back to the 80s and 90s on computer games. And that's it. So it's a visual test, and it's looking at memory, it's looking at visual spatial relationships, it's looking at executive function, it's looking at processing speed, time to response, things like that. And but the beautiful thing is there's no tester bias because the patient is actually doing the entire test themselves. With most screenings, they're pencil and paper. Now, for diagnostics, that makes total sense and it's good. But for screening, if the goal is to rule out disease, rule out something dangerous, a quick self-administered test might be useful. There are right now, there's so many screening tests out there that it's hard to know which one should be the gold standard and what are we measuring against. And this is a big issue now in cognitive screenings because, we have probably the oldest of all of them is the mini mental state exam. And that's a brilliant test. And it's stood the test of time. MoCA is excellent. Minicog is excellent. I mean, so they're all good. They all have their assets. But what do you have to keep in mind? And none of them are standalone. These are all screeners, and they're meant to pass, fail. And if you don't pass a screener, you need a confirmatory test, and that's a diagnostic test. And you can't diagnose based on a screener. It's not the intention or the ability of a screening test to do that.
Sure. So, I mean, just to get a flavor, what are those tasks? Is it tracking stuff with the
Yeah, it's mostly tracking and recall. So you might have one shape that comes up, and it says, "Okay, now find that shape among these shapes," and you move the what.
So if the original shape disappears, and then you have to match it.
Yeah, and then you have competing shapes, and some of them might be as simple as, okay, just follow these busy dots, and you just trace what the dots are doing. And it's always a circle one way or the other, and it's the speed of that. And it calibrates to make up for people who might be slower or faster. So that's a clever thing. Is that
so does it have normative values in it?
Yeah, and those are constantly under valuation and reevaluation based on the data set getting larger and better and tighter. So there are in the Cognivue Thrive, which is the most straightforward screener that most audiologists would look at, there are areas that are normative, and then there are areas that are non-normative.
Okay.
So, yeah.
And so, does vision affect it? I mean, it assumes rehabilitative.
Absolutely. The test is essentially a visual test of your ability to track, remember, look at relationships, recall them, match them, do things like that. So you have to have, corrected vision. If you wear glasses, you must wear them to do this test. This goes back, back in the late 80s before, I'm sorry, back in the early 80s before the FDA approved cochlear implants. Back at the House Ear Institute, I used to do Snell and eye charts on all of our patients. We knew that a patient, because if they couldn't see well, we knew that they weren't going to do as well with a cochlear implant because it's integrating auditory information and visual information to make sense of it in your brain. So we really insisted that everybody had normal vision or corrected vision in the early days. I mean, yes, there are blind patients who eventually got cochlear implants, but not when we were trying to figure out if they were worthwhile. So
yeah. So as I think about it, having a little bit of knowledge of visual processing disorders. So yep. I suspect what you're going to find is some of the population will have that too. But obviously, if you fail, the screening test isn't trying to figure out why you fail. It just finds out that you fail, and then the further evaluation finds out why you fail. Right.
Exactly right. And so the bigger net is exactly as you said. It's kind of a pass fail. We're not trying to determine the causality of that pass or fail. And I can tell you that optometrists are looking at this too. This is a really interesting time in optometry because there are people who do different optometric rehabilitation, visual rehab, things like that, and they would like a reasonably quick and accurate, sensitive measure of how is the patient's overall processing of the visual signal.
Tracking of lines and all of that stuff, skipping lines. Those are all problems, especially in childhood. I had a patient who had a hearing loss who had that problem too. So the patient would deviate lines when they read, so they had reading comprehension issues. That's interesting. Right,
and there are optometrists who do nothing but that. That's their area of specialty.
And that's where that drug was sent to a rehabilitative. I mean, they did other stuff, refractory, but they had a special unit in their practice where they did It's like exercises. It's eye exercise.
Right. And brains are plastic, right? So if we
Right.
have good sensory information going to the brain and we train the brain, retrain the brain, and we reinforce that training, brains do miraculous things. So not every patient every time. We can't fix everyone, but we
Right.
can fix a lot of people. We can't fix people unless we diagnose them first, right? So you
You
start
need
with
to know the
screening.
problem is before you can try to fix it.
Exactly. Well said. Yeah.
I mean,
Yeah, and also part two of that is you can't find what you don't look for, right?
correct. Yeah, fair enough. That's true. Yeah.
And in this world that we're living in 2022, my understanding is Medicare would really like more of us to do more screenings because screenings are generally free. You can't bill Medicare for a screening, and it gets to the patient a higher quality of life more rapidly.
Right. So you're basically find a problem or a potential problem, then go down that pathway rather than just go down the pathway and it be empty, if that makes sense. Right. It
Exactly.
definitely, yeah, I agree 100%. And so getting back kind of the patient experience, obviously, if somebody goes and has a cognitive screen and it's negative, then if they have a hearing loss, they obviously would engage immediately or at some point with the hearing care professional.
Yeah.
If they do have a positive screen, what's the pathway? Where do they go next?
The pathway is pretty much the same. The only difference is refer.
Right.
And generally speaking,
Whom would they expect to go to next?
Yeah. So I would, this is a professional decision made by the professional that you've
Sure.
seen. My preference is almost always I refer back to their GP,
Okay.
and he or she would be the person that decides this looks like a problem. Let's investigate this further. And then they would refer to neuropsych or neurology or whoever the appropriate person is, given the entire patient's history and profile. Because,
Sure.
a screening in and of itself is a little bit out of context. And so, I prefer to give it back to the GP and ask he or she, here's what we did. This is the result. And do you think we should go further? And it's a medical decision.
Yeah. Well, in all honesty, not that but I'm not sure there is enough neuropsychology and neurology manpower out there.
Yeah,
in
that's
terms of to accept all of those positives. I don't think there's not enough bandwidth.
You're exactly right. Listen, a dear friend of mine had a seizure about 2 years ago, and that individual was sent to neurology and took 9 months to get in.
Wow.
9 months, and that's after a seizure, and that's with good insurance. I was blown away, and so I made a bunch of calls to see if I could get her in quicker because I happen to know.
Connection.
Yeah, and I couldn't do a thing. They're just jammed. But that's a major issue. Is we're potentially going to add more people who need to be seen. But that to me is unfortunate. But I don't think we solve that by not referring.
No, I think you actually, from a global healthcare, you have to almost create the problem to get the problem answered.
Yeah, it's a systemic issue.
Right. So you have to create more demand for there to be a response for more manpower. There's very little, it's very seldom that manpower ramps up in anticipation of a need. It's usually in response to a need.
It's usually a response. And it's the same with otolaryngology.
Everywhere.
If I refer a patient, I live in San Antonio and I know a number of excellent neurologists and otologists and otolaryngologists in the city. But, when I refer patients in, sometimes it could take 6 to 8 weeks till they get an appointment. And but that doesn't mean I'm not going to refer. Right.
This is beyond us. It's the nature of the medical system. It's not. Right. People need the care. They need the care. That's the answer. Unfortunately, sometimes it's not as expeditious as we would all like.
And the good news is, if we're doing a cognitive screening, it's rarely an emergency, right? It's a concern, and it says, hey, we should investigate this further. Because, when you think about things like mild cognitive impairment, and when I look at the literature about, above age 60, 65, it's about 1 out of 5 people who has cognitive impairment. But it's mild cognitive impairment. When it starts to affect activities of daily living and getting into dementia, the numbers are quite remarkable. When you read the American Alzheimer's Association, it's about 37 million Americans between age 80 and 85. I'm sorry, I said that wrong. 38% of the population between age 80 and 85. About a third of the 80-year-olds, octogenarians, might have dementia or Alzheimer's in particular.
Right. And 80% of them have a hearing loss that needs to be treated too.
Yeah. So these things often do occur together, and it's a very important thing. So then there's one of the papers I did about 2 or 3 years ago with the British Society of Audiology, we started to look at, well, why would Alzheimer's or all-cause dementia, why would that occur in older folks, and also hearing loss occur in older folks? And there's 4 or 5 operating hypotheses, and nobody knows. But it could be that. Well, what's common to those? Well, one of them could be just neurovascular, just the blood flow. When you think about as you get older and older and older, like me, you develop cholesterol and triglycerides, and you have all sorts of goop on your arteries, right? And the artery exterior wall doesn't get wider and wider. What happens is the inside diameter gets narrower and narrower. So if that's going on in your brain, like the middle cerebral artery, the anterior inferior cerebellar artery, if your blood supply throughout your brain,
or the cochlear artery, right? Just the ones.
That's what I was going to say. And the smallest of all of those, the labyrinthian artery, which is the artery that feeds the cochlea. So maybe the reason that we get cognitive issues as we age and we get hearing loss as we age, maybe it's all neurovascular. I doubt it. I mean, I think there's a lot more, but it's a theory. And the beautiful thing about theories is they make you think through possibilities. So nobody knows the answer, and I'm not proposing that it's all neurovascular, but that's called the common cause hypotheses. And then there's many others. So yeah, you're right. When you're talking about 80 to 85-year-olds, 1 out of 3 has Alzheimer's, and over 2/3 of them have hearing loss. So yeah, if you're seeing an older population, you're going to see these things coexisting in the same patient. And you have to wonder, of all the people that we've seen in the 60s, 70s, and 80s, when they're of that age, we say sensory neural hearing loss, and we stop there because we presume that is covering. That's why they're having difficulties with communication. But there could be so much more involved, and if there is, there might be solutions, particularly if we catch it early. When you talk about somebody early in the phase of cognitive problems, you have speech language pathology. You have neuropsych. You have memory clinics popping up.
There's tons of stuff you can do to keep your brain sharp.
Yeah, and there are whole books written on this. Sanjay Gupta's book, whatever the title was, came out 2 years ago. Keep Your Brain Sharp, or whatever it was. And it's a great book. I read it, and I highly recommend it. And there's brain training exercises online. There's a lot to do, but you don't do any of it unless somebody screened you and then said, "Hey, maybe we should look at this." And then you follow up with your doctor, and sometimes we get lucky and we can change the trajectory of this stuff.
Well, the other thing in my clinical experience, I think it's also obviously a counseling issue, right? And so definitely, earlier in our career, I know that there were poor performers from a cochlear implant point of view, that it was cognitive. It wasn't that the implant wasn't delivering impulses to the cochlear nerve, and then it was being carried to the brain. It was, they just couldn't process the signal, right? And so it's definitely, it's throughout our whole practice of people as we're trying to get them to understand.
And Mark, I'm so glad you said that, because when I was doing the trials at House before FDA approved cochlear implants, I can tell you we used to get full psychological evaluations on all of those cochlear implant candidates for exactly that reason, to make sure that they were prepared and that they could handle that, because it's not easy. You're totally retraining your brain, and your auditory input is about the most significant sensory input you get. So yeah, after approval, we certainly saw some failures, and it doesn't mean the cochlear implant failed. What it meant.
Oh, that's right.
Right.
That's what I say. The implant works. Sometimes the brain can't get the message, and and so having screening tools to find that. And we're screening. So those are important things when you're talking about an undertaking like that.
And this is one of the quotes I came out with this, I think, in 2014. We can make anybody hear, but we can't make anybody listen.
Right.
And that's what you're just
saying. Yeah, exactly. Yeah. Well, this has been great, Doug. I look forward to catching up with you when you're a little further down the pathway with this product. But
I would love it.
This space. I mean, it's not the product, it's the space, right?
Yeah.
The understanding or listening space. So this has been great. And I wish you well on your unretirement. It was short-lived, I will tell you.
Well, I'm following the Tom Brady model.
It seems like it was about 3 weeks from my calculation, but I'll leave it at that.
I didn't count, but it was about the Tom Brady thing. Listen, it's a joy to speak to you. Thank you for the kind invitation. And this is all going to evolve. It's going to get much better, much more succinct, much better numbers and science and outcomes, because people are paying attention to it. So it's going to be great.
If people want to find you or find Cognivue, where do they find you now? I know you've got your own website, right? So
Yeah, douglaslbeck.com is where I reside, and
Yes.
Cognivue is just cognivue.com.
No.
And we're very happy to announce we have an audiology advisory committee that we'll be announcing, I think next week or the week after. Sometime by the end of May, it'll be online, so you can see all the different audiologists and professors and clinicians involved.
That's great. So thank you for coming along. I really
Thanks for
appreciate it.
having me, Mark.
Have a great day.
You too. Thank you.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.